Very good. Okay. Hope everyone is doing fine. Today we have another lecture by Dr. Jamil Al-Farra, and he's with us, alhamdulillah, and we're ready. Hope that you enjoy the lecture today. It's going to be about aneuploidy screening. And you all know Dr. Jamil Farra. Dr. Jamil Farra is a maternal fetal medicine consultant in the United States. He's a dear colleague and a study buddy years ago. And we hope that you attend for this lecture as well as the upcoming lectures. I just want to remind you that to follow the Twitter account to make sure you are up to date with the lectures that are coming in the future. I'm just going to share the Twitter account here, just to make sure that everyone gets to know how to be able to follow the upcoming lectures as well. We have the YouTube account and the Facebook page. Hopefully, we're going to try to have today's lecture live on Facebook. Well, we're just trying to see what happens, if this works or not, but this doesn't substitute attending at Zoom, because I'm sure that it's going to be more stable attending through Zoom. So I hope that we enjoy the lecture for today. I'm just trying to paste the Twitter account. There you go. So for this Twitter account, please register in this account as well as register for the upcoming lectures. Today's lecture is by Dr. Jamil Farra about aneuploidy. And on Saturday, we have Dr. Hanan A, and she is going to be having a very nice talk, inshallah. So Dr. Jamil, welcome, and you can share your screen. I'm going to stop sharing my screen.
Okay, so as usual, I want to start by saying, can you guys hear me? Can everybody hear me and see my screen? Perfect. So I want to welcome you all, and I want to thank Medical Education Without Border and my study buddy from a long time ago, Dr. Badr, for inviting me to give you guys this lecture. So this lecture is not just going to be about aneuploidy screening. It's actually going to be about aneuploidy and much more. So put your seatbelts on and let's kind of be ready. Okay. So speaking of study buddies, this is the medical school that I went to. I'm sure a lot of you are very familiar with King Saud University. Me and Haytham were students in that university. I'm not going to say when, or otherwise this will give away our age, right? Sounds good. Okay. And this is just a screenshot of some of the hospitals that I have actually worked in over the years. For those of you that live in Saudi Arabia, this is the National Guard Hospital, as I remember it. Okay, I know a lot of construction has been done and new buildings have, but for me, this is the symbolic National Guard Hospital, right? This is Stanford Hospital, this is the University of Mississippi, and this is Norton Hospital in Louisville. Okay, so as usual, all of our lecture is consistent with the most recent American College of Obstetrics, Gynecology, and SMFM guidelines. The other thing that I want to remind you all is, you know, if any of you find a mistake in what I'm giving, medicine is a never-ending, you know, it's always evolving. So please point these mistakes out, either email me, stop me, talk to me. Like I have said numerous times, I always learn from giving lectures, whether it's from the preparation, from the interaction. And, you know, I really wish that these lectures were more, you know, face-to-face, because then I can see your expressions and get your feedback and all that sort of stuff. Okay, so are we ready? Everybody has their seatbelts on. Everybody has their cup of coffee ready and is drinking coffee except me, right? And those of us in medicine know how essential coffees are, right? Okay. So again, as usual, Our goal is learning that minimizes memorization. I really want to concentrate on understanding, because if you understand something, it really becomes second nature. It doesn't become a problem anymore. It becomes easy. So a 24-year-old G4P2012 at 20 weeks of pregnancy, presents to you in the office asking, is my baby okay? Very valid question, right? And I think anybody that is in the field of obstetrics, the most important, well, not one of the most important things for expecting moms and parents in general is, do they have a normal baby, right? Is their baby going to be good? So as a doctor, then I have to counsel them and talk to them about what options do I have to reassure them that their baby is fine. So before we start, can some of you tell me what are some of the options that can tell us if her baby is okay or not? So what can I do? What are some of the things that we can do? Yep, I see some very good answers, right? So this is how I want you to think of it, okay? When I say baby okay, right? Does that mean baby okay genetically? Or do I have reassuring fetal testing? And when I look at the baby and I say, is the baby okay genetically? Am I doing a screening test? Or am I doing a diagnostic test, right? And then the next thing that you need to think of, any screening test is going to be one of two, either a blood draw or an ultrasound. Diagnostic tests are all going to be invasive tests, all right? See how it's simple? So now that we understand that little bit of a dilemma, things become much easier, okay? So we have our screening tests, which we said can be ultrasound. And the ultrasound screening tests could be either a nuchal translucency or an anatomic survey. Biochemical markers could be a first trimester screen, a quad screen, or non-invasive prenatal testing. Diagnostic tests, we said, it involves putting a needle somewhere. And that can be chronic villus sampling, amniocentesis, chordocentesis, and so forth, right? Is it clear so far? Is everything clear? All right. Because this is going to set the roadmap moving forward. And once you understand this, it is very, very easy, okay? The other thing that I also want you to ingrain in your head and never forget, put that in your head, engrave it somewhere. A lot of these tests are gestational age dependent, okay? Gestational age dependent, meaning if a mom comes at 12 weeks of pregnancy, what you can offer and what you can do for her is very different than what you can offer to a patient at 17, 18 weeks of pregnancy. Also very different to what you can offer a patient at 30, 34, or 35 weeks of pregnancy. See? So that's how you need to think of it. When I ask, is my baby good? Am I talking about fetal testing, such as NST, biophysical profiles? Am I talking about the baby's genetic components? And if I'm talking about the genetic components, am I talking about screening tests or diagnostic tests? And then the second thing that should come on your mind as well, what is my gestational age? What is my gestational age? Okay, let's move forward. So screening tests do not tell us yes or no. So if I have a positive quad screen, does that tell me that the baby has a Down syndrome? The answer is no. What it does is it tells me that this baby is at an increased risk of Down syndrome. Perfect? Now, if I do an amniocentesis and I have a karyotype, and the karyotype is showing me trisomy 21, then that is diagnostic, okay? Now, also, when we do genetic testing, we're not just looking at chromosome numbers. Sometimes we're looking for deletions, right? Sometimes we're looking for specific genetic disorders. So for example, can I look for cystic fibrosis by doing invasive testing? Absolutely, okay? So you see how, this is kind of my goal in every lecture. What I try and do is put the roadmap, the big roadmap, all right? like my mentors would always tell me, first of all, we look at the forest as a whole, and then we look at the tree, right? So right now, I'm drawing the forest, all right? And then soon we're gonna be moving to the trees. So this is another concept that I think is very, very important. So when I do an ultrasound and I see a hypoplastic heart or an abnormality in the heart, does that mean that there is a genetic syndrome? And the answer is not necessarily. So you can see here, this is why I drew these nice little circles for you. There is a lot of overlap, but sometimes genetic syndromes don't show any structural abnormalities. And sometimes structural abnormalities are not related to genetic syndromes. And that's another point that is an area of confusion. So true or false? If I have a normal anatomic survey, I have ruled out Down syndrome. No, right? If I have an amniocentesis showing me a karyotype that is consistent with Down syndrome, do I absolutely have to find ultrasound findings? The answer is no as well. All right, so you see why this diagram is very important? All right, you know what? I'm very happy with the participation, and I am fairly confident, right, that you guys are gonna enjoy the remainder of the lecture, okay? Do you guys feel good so far? All right, everybody's happy? All right, those of you that ate a lot, stand up, do some jumping jacks, right? Because I know some of you may have eaten a lot, all right? And bring your coffee. All right, like I said, you know, my residents and my medical students know that I enjoy teaching. I love teaching, it's my passion. But I also enjoy teaching and having fun. I also enjoy having fun with my colleagues at work, even when it's not serious, having fun with my patients, because I truly believe that you need to gain the trust of your students, residents, your patients as well, and you need to have a good relationship with your staff, right? So this is what I'm gonna do with you guys. I'm gonna gain this relationship as well. We're gonna have fun. Who said learning can't be fun, right? So what I did here for you is this nice little diagram that kind of summarizes what we just talked about, okay? So we said fetal testing. If we're talking about well-being, it's CS, contraction stress test, NST, BPP. If we're talking about genetic stuff, then screening can include first trimester screen, nuchal translucency, cell-free DNA, quad screen, and ultrasound, right? Now, there are certain conditions where an ultrasound can be diagnostic, right? You don't need to do any further testing. For example, can an ultrasound be diagnostic for an IUFD? Yes, right? Can an ultrasound be diagnostic for anencephaly? Yes. Can an ultrasound be diagnostic for an open neural tube defect? Correct. So you see, so ultrasound can sometimes be diagnostic. Then the genetic diagnostic tests are CVSs, amniocentesis, and chordocentesis. So now that we have laid this wonderful diagram, what do you think is going to be our next step? We said, now this is the big forest, right? We're going to concentrate on the trees. So now for you to not be confused about this, what do I need to know about each test? At what gestational age is it done? Is it diagnostic or screening, right? What is the limitations of this test? What are the risks of this test? And how believable is that test when it's positive or negative, right? Because if I give you a result and it says, you know, the result is an increased risk of X or Y or Z, I'm going to take that result and what am I going to do? I'm going to talk to the patient, and the patient is going to look at me and say, doctor, what are my chances? How accurate is this? Is there a potential that this is not right? You see? So that to me is very important. So in the next couple of slides, I have actually done summary slides for each one of these tests that talks about gestational ages, limitations, accuracy, and so forth. And also what I'm going to do moving forward is we're going to go from the basics, and as the lecture progresses, we're going to talk about the more complex stuff, just like we build a building, right? We start with the foundations and then we build the building as tall as we can. All right, so another way to talk to patients about risk is age, correct? So the age of a 20-year-old of having, the chances of a 20-year-old having Down syndrome is very different than the chances of a 45-year-old having Down syndrome. Now, these are just the select numbers. The table is extremely big if you go back to these references, but I just took like 5-year increments and 37 to show you how the risk increases as the age increases. So let's do some definitions here. What is advanced maternal age? Advanced maternal age is when an expectant mother is going to be 35 at the time of EDC. Now, here is where a lot of you confuse this as well. Does the EDC change, sorry, does the advanced maternal age change in twin pregnancies? Does it change for triplet pregnancies? And the answer is yes. Look here. For every extra baby, you decrease the advanced maternal age by 3 years. So somebody who's carrying triplets, they're considered advanced maternal age at 29 years. Man, can you imagine telling somebody, hey, you're so, what do you call it? The coding here in the United States is very funny. So, and a lot of patients can see what we use to code. So anybody above the age of 35, the code is actually elderly multigravid or elderly nulliparous or something like that. So the patients will come in always and say, am I elderly? I'm like, no, that's just the code that we're using. So can you imagine telling a 29-year-old that you're advanced maternal age and elderly? It's not fun, right? Sounds all right, sounds good. Now, the number that came at AMA initially in advanced maternal age actually came from the loss of a pregnancy when you do a CVS. And they found that the incidence of pregnancy loss when you do a CVS at the age of 35 was similar to the chances of having a baby with Down syndrome at the age of 35. So they said it was warranted that we do a CVS or an amnio for these patients. Now, more studies have been conducted, and they actually then after that with advanced maternal age saw other increased risks with being above the age of 35. And more specifically now, as the data is being gathered more specifically, we're seeing that patients above the age of 37 have increased risks of things like preeclampsia, diabetes, other than aneuploidy, small babies, and so forth, and IUFD. All right. Isn't that a beautiful diagram, right? So what I have done here for you in this little diagram, okay, is the following. Is the gestational age, the test, and at what gestational age it is done. So what do you notice here? Look at the quad screen here. So do you see an overlap between the quad screen and the chorionic villus sampling? There's no overlap. See that? So immediately now, if I walk in and say, here is a quad screen result, what diagnostic testing can you do? What should you eliminate straight away? What diagnostic test can you not do? Just looking at CVS. Exactly. Because by the time I do the CVS, so by the time I do the quad screen, I am outside the window of doing a CVS. See how this diagram helps? On the other hand, cell-free DNA can be done anywhere from 10 weeks till the end of pregnancy. Amniocentesis can only be done at 15 weeks. So if you have somebody with a thickened nuchal at 11 or 12 weeks, do you think it's fair on them to say, you know what, come back when you're 15 weeks so we can do an amnio? No. So they see if you have somebody with an abnormal nuchal translucency that wants diagnostic testing, that it's only fair to do a CVS, right? Now, when I put fetal anatomic survey 18 weeks to 22 weeks, is that exclusive? Can I not do an anatomic survey at 27 weeks, at 28 weeks? I can. But why did I put that from 18 to 22 weeks? Because this is the optimal time where I can see the most amount, right? And at the same time, and this is where it becomes important, in countries where termination of pregnancy is legal and allowed, a lot of countries will not allow you to do termination of pregnancy at viability. So if you see an abnormality, you'd want to do it, you know, before the time where you do terminations. All right. Do you guys like this slide? Does it help understand? All right, perfect. All right, I'm enjoying this lecture. You guys, so here, I'm going to give you a little bit of a secret. You know, I actually finished this lecture about 30 minutes before today's lecture. You know why? Because I love you guys, right? And every single time I said I was done, I'd think of something extra and I say, I'm going to add it because I want to give these people as much information as possible. And then I'll be done and then something else will pop into my head. So this is now giving you a little bit of an insight on my head, right? The wheels are always spinning inside, right? I'm always thinking of other ways to teach. All right, so there are a lot of additions that I added very late on. Sounds good. And I appreciate you all attending, all right? I really do. You know, there's nothing that makes me happier than teaching people and you know, participating in the, you know, advancements of knowledge. All right, so let's talk about now some of these tests that we talked about, right? So ultrasound. What did we say we can do in an ultrasound? Two things, right? We can use a nuchal translucency, and then we can do the fetal anatomic survey. Now, sometimes the ultrasound is done alone. Sometimes it can be done in combination with blood tests. So when we do a nuchal translucency and we draw blood for Pap A, that is a combined test. And what does it look for? It's a combined test. And what does it look for? First trimester screening. Again, looking for those syndromes. All right. So why do we like ultrasound? A, it's not invasive. We think it's safe. It is cheap. It's not very uncomfortable. And, you know, even though we think it's safe, always think in the back of your mind that as the future things, you know, and as developments happen, we may find some adverse effects. However, at this point in time, we think that ultrasound is safe. Okay, so when we talk about a nuchal translucency, now, the only reason I put 10 weeks here is there are some authors that say you can do it as early as 10 weeks. However, most standardized guidelines say that you should do a nuchal translucency between 11 and 13 weeks of pregnancy. What is a nuchal translucency? Does anybody know? What is a nuchal translucency? It is basically just a fancy word of saying looking at the baby's neck. That's all we're doing. We are measuring the baby's neck. And if it is above 3 millimeters, does that tell me that the baby is abnormal? It does not. It is a red flag that tells me that this baby is at an increased risk. Now, the baby is at an increased risk of two things: chromosomal abnormalities, and believe it or not, also structural abnormalities. So here's a question for you guys. Mother comes in, nuchal translucency is, let's say 5 millimeters. Is that normal or abnormal? It's abnormal, absolutely, okay? She then undergoes a CVS. CVS is done. Baby is a normal karyotype of 46XY. What is this mother at an increased risk of? She's now at an increased risk of having structural abnormalities, with the most commonly being cardiac. If you don't find cardiac on the answer choices, then look for abdominal wall defects. Well, see what I'm saying? Now, believe it or not, a lot of people will still pick, when I say that the karyotype is 46XY, what is this baby at risk of? And I have seen it on multiple choice questions where people will still pick Down syndrome, or they will pick monosomy X and so forth. Remember, which one trumps? A screening test that tells you the neck is thick, or a diagnostic test that tells you that the baby is genetically normal? The diagnostic test. However, we still have an abnormality, and that's a neck thickness. So the baby is not out of the woods yet. So that means we have to do a detailed scan to make sure the baby doesn't have abdominal wall defect or cardiac malformations. So nuchal translucency alone picks up about 70% of aneuploidy. Now, also if you include the nasal bone, presence of a nasal bone is reassuring. Absence of a nasal bone could be a marker for aneuploidy as well. Sounds good? Now, when those of you that look at this, and this is a very key statement here, okay, typically performed. So when people say you can perform it at around 10 weeks or 10 points, you have to have a crown rump length of more than 45 millimeters. And you should not perform it when the crown rump length is above 84 millimeters, right? Now, those of you, see, that's one of my other gifts at the end of the lecture, right? And I'm leaving that at the very end of the lecture. Guess what I'm going to give you? The optimal way to measure a nuchal translucency. All right. So that's coming back at the end. So the other part of it, and not just the optimal way and all the prerequisites of measuring a nuchal translucency. Now, we've spoken about a nuchal translucency multiple times. This is what it looks like. Can you see it? This is the baby. This is the back of the baby's neck. And this is the area that we measure. More than 3 millimeters, abnormal. Less than 3 millimeters, normal. This is what an abnormal nuchal translucency looks like. See how this looks thickened? All right. Sounds good. Fetal anatomic survey. Okay. Ideal time, 18 to 22 weeks. Every pregnant lady should be offered a fetal anatomic survey. Now, can somebody tell me what are some of the things on the ultrasound? Some of the stuff on an ultrasound that will make me more suspicious that this baby may have a genetic abnormality. What are some of the ultrasound findings? I want to see each one of you at least say one. At least one by each one. Okay. Short, long bones. Okay. IUGR, absolutely. Echogenic bowel, intracardiac focus, choroid plexus cysts. Right. So the banana sign and the lemon sign that you guys are putting there, those are wonderful. What do they point out to? Increased nuchal fold. Yep, spina bifida, absolutely. So when you see the fruit salad, it is spina bifida, right? And believe it or not, when we talk about the ultrasound lecture, which none of you are going to miss because it's a really wonderful lecture, I am going to show you images of a lot of this stuff that we talked about, including the banana sign, the lemon sign, and all that sort of stuff that you will never forget. Okay, so you guys have nailed it. You guys have absolutely spoken about all of these markers, right? And guess what? I have a slide for you that has, and this is a beautiful slide, And you know, what I have done in my office is one of the you know, our medical you know, EMR system allows me to save dot phrases in it. So I actually went and I put a dot phrase for each one of those. So now every time I counsel the patient, I have it. But this is a beautiful table to look at and have, right? That our wonderful College of Obstetrics and Gynecology has put in one of their publications. So first trimester enlarged nuchal translucency, 3 millimeters, right? And what should we do? Genetic counseling, cell-free DNA, or CVS should be offered, and we should do a detailed anatomic survey. Now, what's the difference between a enlarged nuchal translucency and a cystic hygroma? It is the presence of septations. It is the presence of septations. And remember, cystic hygroma, 50% of the babies are going to have some form of aneuploidy. That is a law. And then of the 50% remaining that are normal, that don't have an aneuploidy, only 20% will be normal. So there is a big chance that this baby with a big cystic hygroma either has an aneuploidy or a structural malformation. Now, when you see cystic hygromas as well, please always think Turner syndrome, okay? When you see echogenic bowel, it is a marker for Down syndrome, and it increases your likelihood ratio by 1.4 to 1.8 for Down syndrome. But other things that can cause an echogenic bowel could be what? Oh, sorry, this is an echogenic cardiac foci. Let's go back, all right? Let's track back. I don't know why I thought it was echogenic bowel. We're talking about an echogenic intracardiac focus. And what is this? This is actually just a bright spot in the baby's heart that we can see when we look at, when we do our ultrasound. So it is not a structural abnormality. It is just a marker for aneuploidy, but it's a weak marker. It's not a very strong marker, right? And usually those, if isolated, they're not highly associated with aneuploidy, but if a patient wants further testing, absolutely they can have it. Now, second trimester pilactuses, or otherwise known as renal pelvis dilatation, renal pelvis dilatation, right? Now that can also be associated with Down syndrome, but if it is not associated with Down syndrome, what should you be thinking of? Remember, kidneys, ureter, bladder, urethra. Have a car accident, what happens? Traffic backs up. You have an obstruction somewhere in your genitourinary tract, urine is going to back up. What are you going to see it as? Dilated renal pelvis, right? So when I see a dilated renal pelvis, counsel the patient about it being a marker for Down syndrome. And I also tell them about the potential of an obstruction. Now, before I forget, the more of these markers that you see, the more concerned you are, right? So if I see an echogenic bowel, short long bones, thickened nuchal fold, not really great, right? If I just see a echogenic intracardiac focus alone, not so bad, okay? Not so bad. All right, then let's talk about echogenic bowel. So when you have an echogenic bowel, you think of aneuploidy, you think of infectious etiology, and in a Caucasian female, what should you always think of? Cystic fibrosis. Cystic fibrosis, absolutely a must, right? Echogenic bowel, you have to. So here's another thing. You know, when we say concentrate about understanding, what is an echogenic bowel? It is merely me being able to see something in the bowel that looks bright. So potentially things that the baby has swallowed or things that the baby cannot get rid of, I will see them as bright. So if we had early first trimester bleeding and then second trimester bleeding and the baby swallowed blood, can that look bright on ultrasound? Absolutely. Babies with cystic fibrosis, they have problems getting rid of mucus. So could I potentially see that as well as a bright bowel? You bet you, okay? See, it's understanding. Now I know why renal pelvis dilatation happens in obstruction. Now I know why echogenic bowel happens. Now, nuchal fold. Nuchal fold by itself, again, is not an abnormality. It's just a finding. And when you measure the back of the baby's neck, now the difference between this and a nuchal translucency is the gestational age that you do the measurement. This is usually done when you do your anatomic survey, and usually you don't do this measurement after 22 weeks, whilst the nuchal translucency is usually not done after 13 weeks. So thickened nuchal fold, it also is the most powerful second trimester marker of aneuploidy and Down syndrome. It's a fluid collection. So again, if I have a fluid collection that is as a result of aneuploidy, I know why. But if I have fluid collection and it's not an aneuploidy, always think, is there a problem in the pump? So again, when you see an increased nuchal translucency, always think of cardiac malformation. Beautiful. Dilated lateral ventricles. If you have dilated lateral ventricles, it could be, again, same principle. Why would the ventricles dilate? See, things go through the brain, right? And they circulate and they go through the spinal cord and the fluid circulates in and out. So I could have dilated ventricles because there is an obstruction, right? Such as the aqueductal stenosis, right? Now, could it also be a marker for Down syndrome? Absolutely. Choroid plexus cysts, they're also potentially markers for aneuploidy. However, their value as isolated markers for aneuploidy, not very high. Now, if you have short long bones, you should always think of, could it be constitutional or genetics? If the mom is 4'11" or 1.4 meters, and she has a small baby, she has a small baby, right? But I need to think about aneuploidy. And what else? If the bones are really, really, really short, what do I need to think of? Skeletal dysplasia. And you know what? Skeletal dysplasia is one of the most difficult topics to understand, right? Now, if you guys, like I said, I'm more than happy, you know, through Dr. Bedr to entertain what topics that you guys like. So whatever topics you guys want us to go through in future lectures, just send Dr. Bedr, send me an email, and then we can make arrangements to have those topics covered. Because I know skeletal dysplasia is not a fun topic, right? But again, just like we did with all the other topics, we'll make it simple. It's steps. And if you know your steps, then you can move on, right? So whenever I think of a skeletal dysplasia is just, for those of you that don't know, is just saying that there is an abnormality in the baby's bones. So for example, osteogenesis imperfecta will be a skeletal dysplasia, right? Okay, and you guys want a pregnancy recurrent loss. All right, perfect. Sounds good. Now, so when we talk about, like I said, abnormalities in the bones, so when I do an ultrasound, can't I potentially see the bone bowed or fractured? Absolutely. So that will alert me that this could be a skeletal dysplasia. Could I potentially see that the shape of the skull looks abnormal? That's going to alert me that this could be a skeletal dysplasia. What about the chest being particularly small in relation to the abdomen, right? And this is another thing that I find very interesting. In the lectures that I give, a lot of times how we deviate and what we deviate into is from the discussions that we go to. So sometimes I wander off because I think I can say a few words that can actually go a long way. So now we kind of gave you a little brief blurb about skeletal dysplasia, right? Abnormalities of the bones are really short, and you see fractures, you see bowing, you see abnormally shaped skull, you see an abnormally shaped chest. All right. So some examples of sonographic findings of other syndromes. So if you see choroid plexus cysts, right, with rocker bottom feet, omphalocele, polyhydramnios, clenched hands, right, you should immediately think of trisomy 18. Now remember, are any of these tests diagnostic? No. These just, so again, whenever you do an ultrasound, right, and this is kind of how you should think about this. I did an ultrasound. I see an abnormality. What do I need to do? Comb tooth this baby to see if there are any other abnormalities. Then if I see those abnormalities, I kind of put them together and see if they fit a picture of a specific syndrome. And then if they do, I tell the patient, look, I did an ultrasound. These are the findings that we find, and I am suspicious that there is a chromosomal abnormality. Then you offer them invasive diagnostic testing. Perfect. So these findings here, right, and this is the choroid, right? These are the choroids, hence why this is a choroid plexus cyst. Now these, irrespective of karyotype, will go away, and they're not problems or structural problems in the baby's brain, but when I see them, we look for other problems. So if I see choroid plexus cyst, and then I see clenched hands, and then I see a VSD and an omphalocele with polyhydramnios, I immediately think trisomy 18. So what do you guys think is the next slide? It's going to be another very famous syndrome. What syndrome do you think we're going to be talking about? Yep, Patel, right? So I want you to remember the P of Patel, right? Because it is going to have holoprosencephaly, right? It is also going to have polyductily. And that's another thing with syndromes. If you look at syndromes, there is a tremendous number of overlap. But if you want to kind of identify a syndrome, especially when you're talking about multiple choice questions, they have to give you something that is unique about the syndrome. And if they give you holoprosencephaly along with polydactyly, your brain should immediately start thinking about Patel, polydactyly, holoprosencephaly. Does anybody know what holoprosencephaly is? Because I always feel if you understand something and you see a picture, it becomes much easier to never forget it. What is holoprosencephaly? Let me see. It is a brain disorder, okay? So what is it? It is actually a failure of fusion, okay? It is a failure of fusion. So the brain doesn't have, see, so let's look back, right? Let's see here. Can you see how the brain here is divided into two parts? You can see the thalami, the cerebellum, the CSP, the falx. See how it's divided? Look at this brain. It's a single ventricle because the brain did not divide properly. Look at that. That's not good. Now, you can also get a proboscis, right? This is the proboscis monkey, right? And when you do an ultrasound, this is what a proboscis looks like. And this is an image that I got from ResearchGate so that I don't infringe. And it's interesting because I do have images of a proboscis and they're actually 3D, but they're in the office. So while I was putting this image, I Googled it, so I had to put the source, all right? So anyhow, but it's a good image, you agree? All right, so now you know what a proboscis is. You know what holoprosencephaly is, right? You see that and you better pick Patel, right? Okay. Are you guys still awake? Come on. I want to see everybody tell me, are you guys awake? Only one person's awake? All right. Are you enjoying the lecture and benefiting? Perfect, perfect, perfect. Yeah, that's more like it, right? So I bet all of you took a good sip of the coffee. I feel jealous. I feel very jealous because I can't take coffee right now. I'm very jealous. Okay, so let's talk about the biochemical screens, right? So a first trimester screen is, now remember, this is the word biochemical. So this does not include a nuchal translucency. It can be done anywhere from 9 weeks to 13 weeks. And what does it include? It is a PAP-A and an HCG. PAP-A and an HCG. If you have a low PAP-A, right, it's associated with both trisomy 18 and 21. But look, I am somebody that likes differences. So a high beta HCG is associated with trisomy 21. A low beta HCG is associated with trisomy 18. It can detect 65% of the aneuploidies, and it does not screen for neural tube defects. Do you think 65% is a good number? I do not, right? 65% is not a very good number to screen for aneuploidy. Now, if we combine this, right, with a nuchal translucency, do we get better results? The answer is yes. We now have about a 90% detection rate. Now, which syndrome do you guys see absent from here? I kid you not, we're going to talk about so many beautiful things that this screening, what syndrome do you not see? Yeah, so first trimester screen and a quad screen cannot screen for trisomy 13. So guess what? If you're doing a multiple choice question and you see the answer trisomy 13, either in a first trimester screen or in a quad screen, don't pick it because it's not right, okay? Sounds good? Now remember, a first trimester screen does not screen for open neural tube defects. So that is one of the advantages of a quad screen, which is done from 15 to 20 weeks, should be offered to all pregnant ladies. What does it look for? What hormones does it look for? Tell me, come on. Beta HCG is always going to be part of the equation. What else? AFP. What else? Inhibin and estrogen, right? Or better known as estriol, all right? Estriol. Perfect? Sounds good. So what is going to happen? This gives me an 80% detection rate, and not so much for, and even less for trisomy 18. And it also has a false positive rate of 5%. So let's look at this table. What do you notice here? Whenever you get a quad screen question, the first thing that you do is you go and look at the AFP. If the AFP is high, you have your answer. You're at an increased risk of open neural tube defects and omphaloceles. If the beta HCG is low, immediately you know that you're at an increased risk of trisomy 18. If the beta HCG is high, then you know that you're at an increased risk of Down syndrome. You know why? Because the rest of the stuff is similar between trisomy 21 and trisomy 18. Doesn't that make it more simple? So now when you look at a quad screen, now, for us in MFM, we look at the quad screen very differently because a low estriol has a lot of meanings, right? And a high beta HCG versus a low. But for the simple part of it, if your HCG is high, you've got Down syndrome. If your HCG is low, you have trisomy 18. And if your AFP is high, you need to screen for open neural tube defects. And that's when your banana sign, your lemon sign has significant importance. So now, what can give me a false positive quad screen? Remember, what did I tell you to engrave in the back of your head? Wrong dates. Because anytime you have it, it's a dating issue. And then what else? Malignancy, absolutely, can cause the AFP to be high and so forth. And also you can have it in severe liver disease. And actually we have a patient with liver cirrhosis that has an elevated AFP, so this does not happen, you know, so it doesn't help. IFD, absolutely. So you guys have nailed a lot of the causes of abnormal quad screen. So if I have an abnormal quad screen, what is the next step in management? What is the next step in management? See, I disagree, right? The next step in management should be always, how believable is my quad screen? And do I find something in the quad screen that can explain my abnormality? So, and that's why questions can sometimes be tricky. If I ask you the next step in management, it will actually be an ultrasound. An ultrasound, okay? Because that will tell me whether my gestational age is correct, whether I have twins, right? Whether I have twins. And it will also tell me if I have an open dural defect. And you know why I also like to do an ultrasound? Because what if I do an ultrasound and I find echogenic bowel, I see dilated lateral ventricles, right? So when I counsel the patient after the ultrasound, it has more value, correct? So the next step in management is an ultrasound. Now, if the patient asks you, what diagnostic test do I need to do? That's when you offer them a amniocentesis, right? Perfect. Which did I miss? All right, so the question about the other parameters, guess what? At the end of the lecture, I have it when the other parameters are abnormal. I've got your back, okay? I think I've answered most of the questions that were thrown at me. Now remember, if I haven't answered the questions, keep them. We'll answer them at the end of the lecture as well, okay? Perfect. Now, incorrect dating can give me a falsely abnormal serum screen. An abnormal should be followed up with an ultrasound exam to confirm dating, to look for explanation, and then we should do genetic counseling and offer further testing. Now here's another question for you guys. We do the ultrasound because the AFP is elevated and we don't see an open neural tube defect. And the patient says, doctor, I absolutely want you to confirm for me that there is no open neural tube defect. You say, okay, I don't see it with ultrasound. Ultrasound is usually fairly accurate, but you want confirmation. What parameter in an amniocentesis can I look for? Right, so Hala, you got the question right. So it's acetylcholine esterase. Why is that diagnostic of an open neural tube defect? Because under normal circumstances, you should not have acetylcholine esterase in the amniotic fluid. Now, could you have AFP in the amniotic fluid? The answer is yes, which means that is why AFP in the amniotic fluid is not diagnostic of open neural tube defect, whilst acetylcholine esterase is. Perfect. Non-invasive prenatal testing, wonderful test that has decreased the number of invasive testing that we're having to do tremendously. It can be done anytime after 10 weeks. And what does it do? It looks for fetal cells or placental cells of fetal origin in the maternal circulation. The more the gestational age, the more cell-free that we can find. Hence, you don't do it before 10 weeks. And potentially, which patients, if you do it after 10 weeks, could you get a no call or low cell fraction? In which patients? Patients that are obese, right? Obesity can definitely decrease your chances of finding cell-free DNA. And this screen comes back as either screen positive or screen negative, high risk, low risk. Now, if a patient comes in and she is high risk for trisomy 21, trisomy 13, and trisomy 18. Now, here's a little bit of statistics for you. What is the difference between, very quickly, sensitivity, specificity, and positive predictive value? Sensitivity, specificity, positive predictive value. What is the difference? In a very simple word, and that's how you need to. Okay? So, this is what I want you to remember. Sensitivity, specificity, you guys don't have wrong answers, but what I was thinking of is one of them is a pre-test, right? And the other one is a post-test. One of them is, what is my ability to detect the abnormal versus this test? Then a positive predictive value is, once I have the result, how believable is it? So now, I tell the patient, man, this is a very, very sensitive test. It can pick up 99.9% of Down syndrome. Wonderful. Do the test, it comes back positive. Then my job is to tell the patient, how believable is that test, right? So guess what? I've got a gift for you guys, right? This is what a NIPT result looks like. It tells us whether it's low risk. It tells us whether it's a female, tells us the fetal fraction. It tells us that they're low risk for the following, right? And it can also look for DiGeorge syndrome. Here's my gift. You guys are ready? There you go. If you ever get an NIPT, that is positive, you go to this website and it tells you the positive predictive value, right? Now, here's another test. Here's another line of thought for you. If we have something that is very prevalent in this in society, our positive predictive value is going to be higher versus something that is not very prevalent in the society, our positive predictive value is going to be lower. So when I have a test that is positive for Down syndrome versus a test that is positive for trisomy 18, which one do you think is going to have a more positive predictive value? The one that is looking for trisomy 21, Down syndrome. Wonderful. So you guys, I advise you to use it. You know, this is a tool that I use very, very often because the other day I had a 21-year-old that came in and her NIPT was positive for trisomy 13. I put it in the calculator and the positive predictive value was 3% with 0 ultrasound findings to suggest a trisomy 13. Do you think that test for me was very believable? Not really. Versus I had a patient who had a positive T18 NIPT, right? With a lot of ultrasound findings, much more believable. All right, sounds good. Now, I know that the NIPT has a tremendous number of uses, right? So for instance, you can actually use it to screen for skeletal dysplasia, screen for cystic fibrosis, all that wonderful stuff. However, it is yet not fully endorsed by the American College of Obstetrics and Gynecology. But I have to tell you, it is a very, very good tool. And I have used it with a lot of success for cystic fibrosis and skeletal dysplasias and all that sort of stuff. But single gene cell-free DNA screening is not currently recommended in pregnancy. But in anything that ACOG doesn't endorse or recommend, you just talk to the patient and you tell her, look, one of the tests is invasive. It tells me answers. The other test is not invasive. It's not endorsed, but these are the, you know, the stuff that we have. So you can always counsel the patient. Chorionic villus sampling from 9 to 13 weeks, right? What it does is it takes placental cells. So immediately when it takes placental cells, what does it not diagnose for? Can it pick up the acetylcholine esterase? It's from the placenta, not from the amniotic fluid. So immediately one of the downfalls of an amniocentesis is it does not screen for open neural tube defects. See how understanding stuff, man, isn't that cool? Now the other thing with the CVS, right? Can it cause complications because of it being an invasive test? Yeah. Could it cause miscarriages, rupture of membrane, limb defect deformities? You bet you. Okay. Now, when people have actually, in experienced hands, when people have adjusted for the rate of spontaneous miscarriages, they actually find that the complications of CVS do not actually, are not higher than the complications of an amnio. Speaking of which, right, just we said, that like what we said, right, the CVS tells me the answer earlier, but it does not screen for neural tube defects. All right. Now, an amniocentesis, let's see how awake you guys are. Other than screening for genetic abnormalities, what can an amniocentesis, what answers can an amniocentesis give me? What can it look for? Come on. Can it look for, I'll help you. Oh, there you go. You guys are answering now. Perfect. Other than karyotyping, can it look for infection? Absolutely. Can it look for bilirubin and anemia? Absolutely. Can it look for fetal lung maturity? Wonderful. You guys are all spot on. Wonderful, wonderful, wonderful. Yes, and absolutely. You can look for single gene disorders, inborn errors of metabolism. What you can do is endless, right? Because you can actually do a microarray. You can do all wonderful stuff that we're going to talk about moving forward. Okay. See how I put everything for you? Timing, indication, description, interpretation. It's a wonderful way of putting it. And that's the way that you guys should think of it. Now, the percutaneous umbilical blood sampling under general conditions should not be your diagnostic modality for chromosomal abnormalities. The only time where you would have to do a PUBS is if your amnio or CVSs came back inconclusive, or they came back showing what you call it, mosaicism. Okay? And yes, of course, but for non-karyotype is for transfusions and things like that. It is a much more complex procedure to do with much more complications, such as, you know, injury to the baby, hemorrhage, IUFD, and so forth. So, congratulate yourselves. We have now covered the basics of aneuploidy, right? And now we're going to go a step further, and we are going to go beyond the basics, right? If you noticed, and when I say beyond the basics, they're still simple. There's a difference. With the end of the lecture, even though they're considered beyond the basics, you guys are still going to get it very right, okay? So don't worry. We're not going to go from ABC to complex stuff. We're going to go from ABC to DE only, all right? So we're still good. You'll still understand. So even if you guys are, whatever level of training you are, we are still going to make it simple, okay? So remember, what did we talk about just now? We talked about the quad screen, right? We didn't talk about the integrated screen, the sequential screen, and so forth. So then you go, well, what are those? I'm going to make it easy. You know what an integrated screen does? The word integrate means put together. I integrate two things, or three things in this matter. So in this integrated screen, what do? I use the first trimester screen, the Nuchal Translucency, and the beta HCG inhibin, AFP, and estriol. So it's the quad screen. Can you see that? So what is the problem with this test? Number one, okay, I have to draw the blood twice. Number two, I don't give out the results till the end of the second trimester. Till the end of the second trimester. So that's not good for the patient. I draw blood at around 12 weeks and then say, hey, come back. And so it's also a problem with patients that are non-compliant and so forth. So that's the downside of the integrated screen. The positive side of it is it actually increases your detection rate for aneuploidy. So that's what an integrated screen is. And yes, it is still a screen. All of these are screening tests. The only diagnostic tests are CVS and Neo. Everything else, including the NIPT, are screening tests, non-diagnostic. Perfect. Now, okay, this is now, remember, this is the integrated screen all together. Everything. This is your combo package, right? This is your golden tier package, right? If you are flying air miles, this is like your golden medallion, right? If you want to move to your silver platter or silver package, what do? Right? All you do is take away, what is the difference between the one that I just showed you and this one? There is no nuchal translucency. So a serum integrated screen is when we don't do a nuchal translucency. See, isn't it easy? These are just fancy words that are not really difficult at all. But a lot of you start to get nausea and vomiting and all that sort of stuff when you hear them. They're not difficult. Quad screen, one test, one blood draw. Integrated screen, 2 blood draws. I'm going to take the first trimester blood, second trimester blood, and a nuchal translucency. And that is called an integrated. If I only want a serum integrated screen, I take away the nuchal translucency. What about a sequential? The other one was integrated from the word integrate. This is sequential, so guess what? It is going to be a sequence, right? Why is this a sequence? Because if somebody tests positive from the first trimester, what do I do with them? I drop them out, tell them that they are high risk. So the only people that get the second blood draw are the people that had a normal first trimester screen. That's why it's a sequence. Absolutely. Okay? Good job. What about the contingent? The contingent, right? So the sequential, only the abnormals drop out. The contingent, both the normal and the abnormal drop out, and they are both told that they are either normal or abnormal, and there's one group that continues, and that is the borderline group. Cool, right? Did you guys think it was that easy? It's all from the name. Integrate, put together. Sequence is in sequence. Contingent means there is a contingency. If you're positive, you go out. If you're negative, you go out. If you're in the middle, we take you to the next round. Okay? Perfect. Guess what? Again, look at this wonderful table. Look at this wonderful table. It takes each one of these tests. It tells you at what gestational age it's done, and it also tells you the detection rate of Down syndrome, advantages and disadvantages, and the method. Right? Isn't that a cool table? It looks busy, but it's a really, really nice, cool table. All right, perfect, perfect. Now, those of you that asked, what if the estriol is low? What if only the estriol is low? Well, that doesn't tell me that the baby has Down syndrome. This could be an indicator of either very incorrect dating, IUFD, or 2 wonderful syndromes. Have any of you heard of these syndromes? Have any of you heard of these syndromes? If you didn't, it's okay. But on multiple choice questions, if they tell you low estriol, the minute you see low estriol on any multiple choice question, or I know there are some attendings here. If you guys want to quiz your residents and quiz your medical students, this is a good question, right? You're like, hey, the quad screen showed a low estriol. What could this baby have, right? So steroid sulfatase deficiency and Smith-Lamelli Opitz. Now I know what the next question is. See, I'm reading your brain. Somebody's going to tell me, well, you mentioned those fancy names, right? You've mentioned those fancy names and you didn't tell me what they were. And this is the Smith-Lamelli Opitz syndrome, right? It is a mutation in the chromosomes that reduces the activity of 7-dehydrocholesterol reductase. So it is a cholesterol production synthesis, right? And you know what does the give me? You know, what is the finding that they usually tell you about? Ambiguous genitalia and syndactyly. Now, if you are like me as a medical student, and Dr. Better can attest to that, we did not do a lot of memorization. If we found a word like syndactyly that was very difficult, we would look it up. So now syndactyly is just a fancy way of saying toes number 2 and 3 are fused. Oh, there you go. Toes number 2 and 3 are fused. That's syndactyly. You see that with ambiguous genitalia. If this was a multiple choice question or a real life question, I see syndactyly, ambiguous genitalia, quad screen is showing low estriol. I counsel the patient about Smith-Lamelli opiate syndrome. Okay, perfect. Good stuff, right? This is the steroid sulfatase deficiency. It is a steroid sulfatase deficiency, right? And it causes scaling of the skin. Now, what if the AFP is elevated? And I do an ultrasound and there is no open neural tube defects. There is no multiple gestations. There is no abdominal wall defects. I don't see a chorioangioma, right? So it could be a triploidy. It could be because of fetal skin disorders, or it can fall under the category of unexplained elevation of the AFP. Unexplained elevation of the AFP, right? An IFD, absolutely. So if I have somebody who has an elevated AFP, it's usually placental function, and that usually indicates, right? That usually indicates that this baby is at risk of having more hypertensive disorders of pregnancy, more placental abruption, preterm birth, IUGR, oligohydramnios, and IFD. So when I have somebody who has unexplained elevation of the AFP, what do I do for them? I do serial growth scans and I enroll them in antenatal testing at the end of pregnancy. Okay? Now, when we do an amnio or a CVS, we have 3 options, right? That you all hear. And believe me, this is going to be I know because you guys have asked so many wonderful, good questions, we've had to go a little bit over time. Do you guys want us to continue or stop? We only have about 5 slides left. What do you want us to do? Do you guys still have the energy to continue? Come on, only one person has the energy? Continue, all right. They're really, really, really important slides, but you know, so good, perfect. So when we do an amnio, right, or do a CVS, there are 3 potential tests that we can do. We can do a karyotype, we can do a FISH, and we can do a microarray. So the important thing is to say, well, what is the differences between them? When do I do this? When do I do that? What are the limitations of each? So a karyotype is basically telling me the number, right? So it identifies aneuploidies. Aneuploidies are things that are an increase in number or a decrease in number. It also identifies trisomies as well, right? And it views the entire genome. It has to be done in the metaphase phase, and it needs live cells. They need actively growing cells, and that's usually done via lymphocytes. Why am I saying this? Because if I have something that now is done at a specific phase, and it has to be growing, if that culture is not taken in a timely fashion or the baby is not alive, can I do a karyotype reliably? The answer is no, okay? So then there must be another test that is more superior, right? If I have cells that are not dividing, not in metaphase, and last but not least, right? If I have cells that I need to look at that are much, much smaller than what I karyotype with. So the resolution limit of a karyotype is not megabytes, megabases, right? 5 megabases. So if I have something that is less than 5 megabases, karyotype analysis is not good. So I'll give you an example. If I have somebody who I think has trisomy 21, and I do a karyotype, and karyotype comes back showing me trisomy 21, do I need to do something else? The answer is no, right? Now, if I have multiple ultrasound findings, and the karyotype comes back normal, then there may be something smaller that I didn't pick up, right? There may be variations in the chromosome. There may be small deletions, additions, all that sort of stuff. That's when a microarray becomes more superior, right? Now, this is a normal karyotype. Can you see how there's 2 pairs of chromosomes, 1 through 22, and then there is the 6 chromosomes. Is this clear? Right? See what a karyotype looks like? It looks like this. Now, what do you see that is abnormal in this karyotype? 2, 2, 2, 2, 2, whoops, 3. So what is this? A karyotype of a Down syndrome baby. There's an extra 21. Now, the way that I remember fish is you go fishing, right? You go fishing for something. So you have to have a fluorescent labeled probe. You have to know what you are looking for. So a fish doesn't look for everything. It has a specific, it's like a torpedo, right? It has to target something specific, go to it, pick it up. Sounds good? So you have to. Now you can do the probe for whatever you want, but if your probe is not looking for a specific something, you're not going to find it. Why do we do fish? Because it's much more rapid than a regular karyotype. It can give me the results within 2 days versus 7 to 14 days, but it comes with a pinch of salt. It has both false positives and false negatives. But it also does not need to be cultured for metaphase. Now, how many of you are interested in seeing what a fish looks like? Not the fish that swims, but the fish, right? Guess who has one for you? I do. So, see this here? Right? Can you guys probably have better eyesight than I do. Can you see these two green dots? These are the probes that are used to tag chromosome 22. So now I know I have 2 chromosome 22s under the 2 green dots. See, 1, 2. The red dot is the one that is targeting the DiGeorge region. And if you see here, there's only 1 red dot. What does that mean? The other chromosome is missing the red dot. So there is no DiGeorge gene, right? Isn't that cool? So that's how we actually diagnose DiGeorge syndrome on a fish. All right. I want you to look at the microarray. If this is the only thing that you get out of this, a microarray is exactly the same as a karyotype, but we use a bigger magnifying glass. Does that make sense? So I can see better resolution. So those of you that have bad cameras, your resolution is bad. You have good cameras, you see a lot of stuff. All right, so a chromosomal array, we have a reference gene and we have the gene that we pull from the mother. We compare them. We see the areas where there's extra or missing stuff. That way we can know if there's deletions, there's expansions, and all sorts of stuff. Now, it does not need a cell that is replicating. So this is much better for babies that have IUFDs, right? IUFDs, and it's much better for chromosomal abnormalities with that need higher resolution, so small micro deletions. All right, I think we have covered a lot of the micro, and I don't want to go into more details than that, right? Fish, you have to fish for something specific. Karyotype does not detect very small deletions, but tells me triploidies, tells me aneuploidy. Chromosomal microarray looks for even the smallest of things. Those of you that wanted the protocol for the measurement, and these are my last 2 slides, I promise, okay? Those of you that wanted the protocols for the measurement of the nuchal translucency, there you go. Okay, it has to be from 11 to 13 weeks. Crown rump has to be 45 to 84 millimeters. And we have to have a mid-sagittal view where we see the tip of the nose we see the face, we see the echogenic tip of the nose, the rectangular shape of the palate, right? And we also see the translucent diencephalon over there. The fetus should be in the neutral position, because if the baby's doing this, you're going to get a hyperextended neck and a potentially thicker area, all right? And then the measurement can be falsely increased or decreased. You have to be able to distinguish the skin from the amnion so that you don't, by mistake, take the nuchal translucency with the amnion in it. Measurements must be taken from the inner border, and you must take multiple measurements. Okay? Please do not forget to follow us on Twitter, whether it's medical education on Without Borders, or I also enjoy it when you guys follow me on Twitter, so don't forget to do that. Now, the other thing that I also want to point out is I want to continue through Medical Education Without Borders. I have been putting questions. I hope that you guys have found these questions beneficial, but I do want more participation. Remember, the more participation that you guys give me, the more participation, the more I'm going to be motivated to put more questions. Okay. All right. I hope so. Now, those of you that, like I said, you guys have my email. If there's something that I missed from the questions that I didn't, I did not answer, please go ahead and email me. Okay.
Thank you very much, Dr. Jamil. It was a beautiful lecture. I saw a few questions written. Let me just go back to them. Okay, let me see. I'm going up. They're writing in. So, guys, do you have any questions? Can it be placental aromatase deficiency? Like I think
yes,
I saw.
Yes, it can. Absolutely.
Okay. Have you gone through the questions? Like there are some questions in the
Like
channel.
I said, if there's any questions, just email me. I have emailed everybody. Yeah. I have emailed everybody back. I promise. I email everybody back. And sometimes, these detailed questions, what I've done a lot of times is I've actually emailed back very good references. So don't hesitate to email me or even, ask me the question through Twitter or Medical Education Without Borders.
Excellent, excellent. So let's post the questions on Medical Education Without Borders. I'm going to now put in the registration for the next lecture, which is going to be on Saturday, and it's going to be about endometriosis. So please register from now, and you can follow the Twitter account as well to make sure that you register for it. You're going to receive the email that allows you to enter into the lecture. Thank you very much again, Dr. Jamil. It was a wonderful lecture, and we'll see you soon.
All right, you guys take care.
Take care, everyone.